Hello. On behalf of the Center for Health Innovation, CHI, I'd like to welcome you to this brief webinar on academic detailing. CHI is a nonprofit organization that works around the state to advance public health practice and make systemic changes in population health. We do this through prevention and community collaborations, healthcare workforce development, and network and systems planning efforts to address health issues facing New Mexicans. Public health institutes are generally nonprofit organizations independent from state government and educational institutions. Through public health institutes, public and population health initiatives are delivered through innovative partnerships. Local and state strengths and assets are identified and leveraged. Current and emerging health issues are addressed through research, policy, and system transformation. So here at CHI, we do a little of all of that. So we've already talked about who is Center for Health Innovation. In addition to that, today during this webinar, we will be covering the following. What is academic detailing? Why is AD or academic detailing a solution in New Mexico? Who is this service for? And where and when is the service provided? Before we dive into academic detailing, let's give a little background on the health issue we're applying it to. We are still facing unprecedented overdoses from opioids and other controlled substances. The misuse of opioids, including prescription pain relievers, heroin, and synthetic opioids such as fentanyl, is a serious national crisis that affects public health as well as social and economic welfare. In 2013, New Mexico had the second highest rates of opioid overdose deaths in the country. We have now shifted to number 15, but unfortunately, it's not necessarily because we are making many improvements, but rather other states are just doing worse. New Mexico still has the highest rates of opioid overdose deaths west of the Mississippi. One access point to opioids is through valid prescriptions from healthcare providers. Opioids have been commonly prescribed over the last few decades for chronic pain. There can definitely be a time and a place for opioid prescriptions. Unfortunately, healthcare providers were given very misleading information from pharmaceutical companies that led to drastically overprescribing them to patients. Here we see that contrary to popular belief that most opioids are prescribed by specialists, in actuality, the majority of opioids in New Mexico are prescribed by primary care providers. When looking at opioid use disorder through a public health lens, we need to look at the different mechanisms of prevention. Primary prevention is trying to prevent a disease from occurring in the first place. Secondary prevention is trying to detect a disease early and prevent it from getting worse. Tertiary prevention is once a disease is present, the focus is on improving quality of life and reducing the severity of the symptoms. Academic detailing, as a strategy that provides guidance, education, and resources to healthcare providers, is really the focus of primary prevention. But how do we provide that support when healthcare providers have many competing demands for their time? Trying on their own to assemble current evidence from a continuous influx of research is incredibly challenging. As a result, many healthcare providers may be unaware of better alternatives for prescribing, prevention, screening, and patient education. Healthcare providers need an accurate, ongoing source of current data about comparative effectiveness and safety. We've come a long way in healthcare. We have tons of knowledge about what works. There have been tremendous reductions in morbidity and mortality, advances in treatments, and we've acquired lots of knowledge about diagnostics, medications, and different ways of caring for patients. The problem is translating that knowledge into practice. When healthcare providers are faced with mountains of evidence, hundreds of journal articles are published every day with tons of articles in each of them. How is one to process all that information? Digesting that information and actually changing practice is extremely difficult. Traditional methods for disseminating evidence-based information does not guide or change clinical behavior. In fact, it can take up to 17 years for proven information to adopt evidence-based guidelines and change clinical behaviors. And of course, by then, there are new best practices. Unless we have methods to efficiently process that new information, then we've really lost all the investment and all the knowledge that we've gained in generating that information about how to best care for our patients. Academic detailing is one solution. Academic detailing is a translator to overcome the gap between what is known and what is done, so that all of the great scientific knowledge that has been accumulated is not underutilized. Academic detailing can bring value to the evidence, otherwise it's just a pile of unread evidence. Here's the logic of academic detailing. Medical and pharmacy school faculties have a solid grasp of evidence about drug benefits and risks, but they're not always the best communicators. It's usually very didactic, visually boring, no idea of a single provider's attitude, beliefs, or perspectives. Pharmaceutical industry representatives, on the other hand, are excellent communicators, but their primary goal is to increase sales. They go to the healthcare provider, it's very interactive, the content is simple and straightforward, and the goal is behavior change. We know this is the case from decades of experience and scores of randomized controlled trials. When the pharmaceutical drug industry wants to change what we know about its products, it sends people to the clinics to talk with the healthcare providers. It doesn't rely only on the less expensive modalities of mail, email, sponsored lectures, things like that. The most cost-effective is not usually the most effective overall. Academic detailing is when the content of academia is communicated to providers through the delivery system of the pharmaceutical reps. Academic detailing has been around for almost 40 years. However, recently it has gained the attention of a few national health entities, including AHRQ, or the Agency for Healthcare Research and Quality, and also the CDC, or Centers for Disease Control. As previously mentioned, academic detailing is a translator. Researchers take the best and most current evidence and make it practice relevant, and then share it with healthcare providers so that they can use the information to care for their patients. Academic detailing is a one-on-one personalized service that allows information being shared to be tailored to the healthcare provider based on their specific needs, which in turn can lead to the development of a trusted relationship between the academic detailer and the healthcare provider. Academic detailing relies on one-on-one interactive communication because this allows the outreach educator or academic detailer to truly understand the provider's current practices, attitudes, and beliefs, to tailor the information and resources available to the needs of the provider, to keep the provider engaged. The initial session includes a comprehensive needs assessment where we ask things like, share with me how often you face diagnosing and treating patients for chronic pain. What type of chronic pain do you see most in your patients? What challenges do you find in treating chronic pain? What do your patients expect from you as their provider? What resources do you go to for the treatment of pain management? Through this process, detailers are able to then match up-to-date and evidence-based resources with the needs of the provider. Our current menu of options is centered around 6 key messages. The first, how to establish goals for pain and function. The second, use non-opioid treatments for the first line of treatment. Number 3, always start prescribing at the lowest effective dose if opioids are chosen for treatment. 4, using the Prescription Monitoring Program, or PMP, to review a patient's history of controlled substances. 5, co-prescribe naloxone to all patients that receive a prescription for opioids. And 6, how and when to consider tapering or discontinuing an opioid medication. In an effort to stay current on the needs and provide relevant and timely information, we have also developed a supplement to the initial provider guide, including best practices around using telemedicine to evaluate patients and continue existing opioid prescriptions. Also, evaluating risks and benefits of steroid medications and using a decreased dose, especially for those at high risk for COVID-19, since steroids can suppress the immune system. The supplement also includes an overview of the DEA's adopted policies that allow DEA registered practitioners to prescribe controlled substances without having to interact in person with their patients. So there you have it. Update New Mexico is New Mexico's academic detailing program. The funding for this program is by the New Mexico Department of Health. We currently have a team of 10 trained professional contract academic detailers that are supported by a clinical support team. We will meet your educational needs for pain management CME if you are licensed here in the state of New Mexico. Please contact us at your earliest convenience to schedule your first session. Thank you and be well.